The foundational mechanism of cardiovascular disease is well established. Lifetime cumulative exposure to ApoB-containing lipoproteins is the principal causal driver of coronary atherosclerosis. We also know exactly what happens under intensive pharmacotherapy. Sufficiently aggressive ApoB lowering via statins or PCSK9 inhibitors physically shifts plaque trajectories away from progression and toward regression. This scatterplot of the cholesterol treatment trialists' data demonstrates a predictable relationship. Vascular events fall proportionally as LDL drops, but anomalies emerge from dietary interventions. Primate and CardioPrev data points fall far below this line, showing massive event reduction despite minimal LDL separation. In adjusted analyses, these Mediterranean dietary trials reported roughly 25 to 30% reductions in cardiovascular events relative to their comparators. These highly significant clinical outcome effects occurred with negligible between-group separation in fasting LDL cholesterol. This creates a direct discordance. If fasting ApoB isn't dropping proportionately, unseen physiological mechanisms must be driving this dramatic reduction in clinical risk. This discordance frequently fuels a clinical debate over whether diet is superior to pharmacotherapy or vice versa. That debate rests on a specific physiological assumption that cardiovascular risk reduction strictly requires the physical debulking of plaque volume. Lumen capacity is not a simple inverse function of total plaque volume. Diet and pharmacotherapy operate on partially separable biological axes, interacting with arterial anatomy and hemodynamics in entirely different ways. Asking which therapy is superior creates a false dichotomy. The discrepancy in the data exists because historical dietary trials and modern pharmacological trials measured completely different physiological phenomena. To understand the data, we have to look at the anatomical framework. Arterial health is not a single variable. It exists along three partially separable phenotypic axes. This illustrates axis 1, plaque volume. Here, the plaque annulus thickens or thins, while the external vessel boundary remains rigidly fixed. Moving to axis 2, lumen caliber and remodeling. Here, overall vessel and channel dimensions change independently of plaque volume. Within axis 2, we observe Glagg-Valve's compensatory enlargement. As early plaque accumulates, the artery expands outwardly, preserving the blood channel until the plaque burden reaches approximately 40% of the internal area. The reverse is constrictive remodeling. During regression, a vessel can shrink inward, causing the lumen to narrow even as total plaque volume decreases. Finally, axis 3 measures plaque composition. Without changing volume or caliber, tissue character shifts from a high-risk, lipid-rich core to a stable, calcified lesion with a thick, fibrous cap. High-risk compositional features, specifically low attenuation plaque burden, often dictate spontaneous infarction risk more accurately than the severity of the stenosis itself. Therefore, an intervention can successfully stabilize a vulnerable plaque on axis 3 and outwardly expand the vessel on axis 2 without ever reducing total plaque volume on axis 1. It would register as a total failure on standard volumetric endpoints while drastically lowering patient risk. The historical evidence base for intensive dietary interventions, including the Lifestyle Heart Trial, relied almost entirely on quantitative coronary angiography. This angiogram reveals the procedure's physical limitation. It images the contrast dye filling the channel. It tells you nothing about the arterial wall itself. Because angiography cannot see the vessel wall, it completely misses Glagg-Valve outward remodeling during disease progression, and it misses constrictive remodeling during regression. Modern pharmacological ApoB-lowering trials, such as Glagg-Valve and Pacman AMI, avoided this limitation. This split screen compares the older angiographic silhouette to modern intravascular ultrasound and optical coherence tomography. These modern instruments reveal the hitting plaque burden located entirely outside the dye column. IVUS and OCT can definitively measure wall burden, lipid core depletion, and fibrous cap thickness, capturing activity on axis 1 and axis 3. Comparing historical dietary angiographic data against modern pharmacological IVUS data is scientifically invalid. They are incompatible rulers, measuring completely different biological axes. The clearest demonstration of vascular behavior during lipid-lowering protocols comes from a study of Cynomolgus macaques conducted by Williams and colleagues. After 30 months of lipid lowering, the vessel and lumen cross-sectional areas roughly doubled. This geometric expansion occurred with no significant reduction in actual plaque area. The metabolically active lipid compartment mobilized, but the structural fibrocalcific intimal scarring remained permanently in place. Translating this biomechanic to human dietary physiology provides a clear mechanism. High-quality dietary patterns alter basal endothelial tone and modulate endothelial nitric oxide signaling. Diet simultaneously lowers systemic inflammatory tone, reflected in metrics like CRP, which directly alters how much cellular damage a retained ApoB particle produces. Improved vasomotor tone and outward remodeling can effectively widen the roadway and restore perfusion, completely independently of towing away the plaque cars. To evaluate dietary efficacy properly, we must examine the actual magnitude of ApoB and LDL cholesterol reduction achievable by plant-predominant or vegan diets. Highly controlled feeding trials, such as those conducted on patients with familial hypercholesterolemia, yield an approximate 18% drop in LDL cholesterol. Pooled data from population-level vegetarian and vegan trials show an even smaller effect, averaging only a 10 to 15% reduction in LDL-C and ApoB. Intensive combination pharmacotherapy routinely reduces LDL cholesterol by more than 50%. There is zero clinical evidence that diet delivers more lumen stability or perfusion per unit of ApoB reduction than pharmacotherapy. For high-risk patients, diet is mathematically insufficient as a standalone tool for the intensive ApoB debulking required to halt atherosclerotic progression. Returning to our initial discordance, if diet isn't driving extreme ApoB clearance, where does the 25 to 30% clinical event reduction actually come from? Dietary patterns act concurrently on multiple ApoB interacting and concentration-independent pathways. This analytical matrix illustrates the division of labor. While drugs manage atheroma volume and lipid core, dietary interventions modify endothelial function, blood pressure, and postprandial lipemic exposure. Pharmacotherapy is highly optimized for lowering lifetime cumulative ApoB exposure and physically debulking the active lipid compartment. Diet operates dynamically on vascular biology, mitigating the inflammatory and hemodynamic damage caused by whatever particles remain. True clinical excellence requires complementing the longitudinal ApoB reduction of modern pharmacotherapy with the systemic vascular optimization of a high-quality dietary pattern.